Progesterone is absolutely essential in the luteal phase, as some classic studies by Sapo et al. Had demonstrated. Without the presence of the corpus luteum in early pregnancy, the pregnancy is fated for demise. We know that progesterone is what's responsible for decidualization and for inducing the implantation window in the endometrium. In programmed frozen embryo transfer cycles where there's no corpus luteum present, progesterone replacement is essential. And to establish what's the optimal frozen endometrial transfer protocol will ultimately benefit our patients in terms of optimization of live birth rates. While I acknowledge, based on our own data and those data of others, that there is certainly a threshold below which progesterone is inadequate for optimization of live birth rates and implantation, because we use intramuscular progesterone in all of our frozen embryo transfer cycles, we don't test the thresholds or test the progesterone serum concentrations prior to transfer. We know that with intramuscular progesterone supplementation, at least once every third day in replacement cycles, the chances of having a progesterone serum concentration that's inadequate is very, very low. So based on our randomized controlled trial data, we know that some form of systemic progesterone is necessary to achieve optimization of live birth from frozen embryo transfer. We do know that from prior data, oral progesterone is absolutely inadequate in terms of its bioavailability and chances of implantation and live birth. The question that was outstanding prior to completion of our randomized controlled trial was whether vaginal progesterone alone was adequate. And what we found from our randomized controlled trial was that progesterone delivered vaginally in and of itself was inadequate. However, progesterone that was supplemented vaginally with intramuscular every third day was sufficient to achieve optimization of live birth, statistically equivalent to that achieved by daily intramuscular progesterone. So data that's available on subcutaneous progesterone has shown that it is in fact bioavailable and does achieve fairly reliable serum progesterone concentrations. We know also that subcutaneous progesterone is sufficient in terms of obtaining adequate live birth rates, essentially that are comparable to those of vaginal progesterone for fresh IVF embryo transfer. Certainly, if given the option of vaginal with subcutaneous versus vaginal alone, I would advise my patient to use subcutaneous as a supplementation on account of our data showing that systemic progesterone is needed. That said, my feeling is that randomized controlled trial data is needed that compares the subcutaneous progesterone to intramuscular in order to know for certain that that optimal live birth rates are achieved. All the historic data has indicated that oral progesterone is insufficient. Very poor bioavailability of oral progesterone has been demonstrated in terms of serum levels. That said, there's some interesting work in a Chinese study in PLOS-1 recently that showed vaginal progesterone to be equivalent to intramuscular progesterone when both arms were supplemented with oral. That study was very disparate from the way that we practice in the United States with vitrified warmed blastocyst transfer. It was a very young population of patients and a population that largely underwent cleavage stage transfer. So it's hard to know whether that data is applicable to the way that we practice here and the way that IVF is largely performed in Europe in terms of frozen embryo transfer. That said, I do think that it's an area of interest and one in which additional randomized controlled trial data is needed. I think there are many potential mechanisms by which systemic progesterone could be assisting vaginal in optimization of live birth rates and prevention to some extent of miscarriage. I do think that changes in terms of vaginal absorption in early pregnancy is one very compelling explanation. Whether or not that's due to changes in the microbiome or other physiologic changes in terms of vaginal absorption, I really can't comment in the absence of data, but I think it's a very interesting avenue of pursuit from a mechanistic standpoint. I do think that other mechanisms may also explain, for example, peripheral metabolites of systemic progesterone, potentially decreased uterine contractility, and even potentially positive impact of immunity, again tying into microbiome owing to systemic progesterone.